Welcome to the expert perspective on salvage treatment in metastatic colorectal cancer. My name is Gerald Prager from the Medical University of Vienna. I'm a GI cancer expert, and I'm happy to discuss today with two experts in the fields, Professor Van Cutsem from Leuven, Belgium, and Professor Bekaii-Saab from the May Clinic in Arizona. Welcome.
Thank you.
Thank you.
So the metastatic colorectal cancer is still the second common reason for cancer-related deaths in the Western world. And luckily, we have introduced into the clinic new drugs in the treatment of metastatic colorectal cancer in patients who have been pre-treated and are resistant to IV drugs. One is TAS-102, the other one is regorafenib. So two oral administered drugs. And we want to discuss today what is the right sequence, or is there any right sequence in administering these drugs in patients who are fit enough to be treated in a salvage setting. Professor Van Cutsem, we have seen clinical phase 3 trials which led to the approval of these drugs. How can you put the data from these clinical trials into the daily clinical setting?
Well, the data of these two clinical trials were in the same setting. They were all done in patients with metastatic colorectal cancer, good condition, good organ function, refractory to the different cytotoxics, fluoropyrimidines, oxaliplatin, irinotecan, and as well to the biologicals, bevacizumab, and in the RAS wild-type patients to the anti-EGFR antibodies. The trials with both drugs were randomized trials of regorafenib versus placebo, or TAS-102, which is now called trifluridine tipiracil versus placebo. So in the same setting. And I think since the trials were both positive, that we should place the drugs in this typical setting, chemorefractory patients. That's where the trials have been done.
So 20% of the patients treated in the RECORS trial, so in the trial with TAS-102, were pre-treated with regorafenib. Is this something which leads your decision in the clinical setting that you should give first regorafenib, or doesn't this play any role into your decision making?
Yeah, that's a very interesting and applicable clinical question. I mean, the question, like Dr. Van Cutsem was talking about, is you have two studies showing two agents working similarly in the same setting, but they've never been compared head to head. And the question is, you see the patient in clinic, so what do you do? Which one you start with first? So there is no real guidance, from a clinical trial, except, as you said, the RECORS study tells us that if you're exposed to regorafenib or not, you tend to derive the same benefit. Unfortunately, we don't have the same set of data with the other way around. Whether that plays a major role or not, I am not sure. But in my clinic, at least that's how I would place them. Whenever possible, regorafenib first, then TAS-102, just because of the presence of this data. And there is also other data from the Asian trials, and maybe we'll touch upon those, that suggest that if you move regorafenib to earlier settings or less pre-exposed patients, your delta widens, whereas TAS-102 seems to keep that balance. Well, from the TERRA study, whether you go up or go down, you maintain about the same benefits. But I think the cleanest way to get that answer is to have a head-to-head study, which I suspect will never happen.
Okay. So within these both clinical trials, only patients were allowed to have a very good performance status, equals 0 or 1. The daily clinical life looks a little bit different. We see patients who are willing to be treated, but they are in the, let's say, moderate performance status, ECOG 2. Do we have a preferable choice of treatment for those patients with ECOG 2?
I think if we just stick to the data were, and the studies were done in patients with an ECOG performance 0 and 1. Having said that, the benefit remains relatively modest of these drugs. The drugs show the benefit, but the benefit is modest. So I think stressing to the physicians that good condition, good organ function is important. And especially also if you look at regorafenib, which has in patients with worse outcome, worse condition and worse performance state, there's a little bit more toxicity. I think selection is important for good condition. And to be honest, we don't have data of TAS-102 in patients with an ECOG performance 2. I expect there is no problem, but we don't have the data in this situation. So if a patient is in a bit of worse condition, I think then this may be rather a candidate for TAS-102 compared to regorafenib in view of the slightly higher toxicity with regorafenib.
So in the clinical phase 2 trial, TAS-102 was also allowed for patients with moderate performance status, ECOG 2. So there are few data, at least on these patients. But talking about side effects, the side effect profile of these two drugs is, let's say, totally different. They have a different mode of action. The one is a tyrosine kinase inhibitor, the other is an anti-metabolic drug. Can you comment on this?
Yeah, of course. They are very different drugs. One is a multi-kinase inhibitor and comes with all the toxicities that you would expect with multi-kinase inhibitors, although it tends to have them a little bit earlier than most. Within the first 2 to 3 weeks, you would see hand and foot syndrome at its worst, up to 4 weeks, fatigue, and hypertension, which is expected for this class of agents. With TAS-102, the biggest toxicity, at least on the short term, is neutropenia and febrile neutropenia. I mean, we have to remember this is a cytotoxic agent, and it seems to induce, about 4% of febrile neutropenia, which is not insignificant. On the longer term, you start seeing more GI toxicities and fatigue, as again you would expect with the cytotoxic agents. So they have different toxicity profiles, and that is an important point when it comes to, again, selection. So when we talk about performance status that's poor, I think it makes more sense to do the TAS-102 again with caution. As Dr. Van Cutsem says, we don't have enough data to push this further. When it comes to regorafenib, the question, of course, is should you start with 160 versus a lower dose and escalate? Now, the data we have today is on the 160. We have a little bit of scattered data here and there about experiences with lower dose and escalation. We have a study that's about to complete, the redose study, then we're hoping to present the data early 2018 that has compared the two strategies of dose escalation versus starting with 160. Right now, it's a personal preference since, as everyone mentioned, we're talking about a very modest benefit, which is progression-free survival of close to 2 months. I personally choose to start with the highest dose rather than to experiment with the unknown until we have more results.
Okay.
Yeah, but if you look, indeed, the data that are always cited with regorafenib are with 160 milligrams, the classic approved dose. But in clinical practice, if you do polls or if you ask to most physicians or at panels at different meetings, you see, and that's also what I do in clinical practice, I start most of my patients with 120 milligrams. And then this safety aspect is of a lesser problem. And then both drugs are probably more comparable regarding safety profile. The pattern of toxicity remains different, but if you look then in the number of safety issues and adverse events with 120 milligrams compared to the TAS-102, there's probably not a big difference anymore if you just look numerically at that. But it's completely correct at what you say, that we have to look at the data, looking at activity, whether the 120 milligrams is as active. There is a US trial, there is a European academic trial that is being launched also to answer that question formally indeed.
How important is it to proactively manage side effects when we talk about regorafenib? Do you see your patients every week in the first 2 cycles, or how do you manage this?
It is important to have to give good information to the patients. We don't see them every week. We see them every 2 weeks. But we instruct the patients clearly that if they have some adverse events in the first week or at whichever moment, that they have to call and that they should come back at that moment to cross-check. But instruction, education of patients through the physicians, through the nurses is extremely important because with the early management of the safety of the toxicity, you can avoid running them into more serious problems. And that's very important, especially with regorafenib.
How do you do it in Mayo Clinic?
So we actually tend to be a little bit more conservative. We start with every week, at least in the first 4 weeks. But you know, the physician doesn't have to see the patient every week. It's actually, we have the nurse practitioner probably seeing those patients. But we see them every week for the first 4 weeks, then every 2 weeks for the next cycle. And after they get to the couple of months, you really would have figured out the right dose, and if they have responded, i.e., you know, they mostly have stable disease, then we start seeing them every month. As long as they're benefiting from the drug. And most of this is because, again, you're going to see those toxicities in the first 2 to 3 weeks. And not only you're more likely to see them, but they also come at their worst grade. And so you can adjust the doses better if you see them every week or every other week, I think is also reasonable.
Let's talk about task 1 and 2. Let's say it's a little bit unusual administration of the drug, 5 days on, 2 days off, 5 other days on, 16 days off. How important is it to educate your patients that they know how to take the task 1 and 2?
Yeah, that's these are all oral medications are tricky with our patients with cancer. And there are other factors that go in the equation that lead. I mean, we've seen that with capecitabine a long time ago. Patients skip doses, they don't feel as good that day, or they get confused about when to stop and when to start. So we try as much as possible to be very consistent. You start on Monday, you finish on Friday, and then you get 2 days off. You give them papers. You make sure you give them the schedules and all this. But I can tell you that with all this, and there's still some level of confusion, there's skip doses here and there. Now, whether it matters in the big picture or not, in terms of outcome, not sure. We tend to see them again on a weekly basis, at least the first 2 to 3 weeks. Their blood counts, we try to get them staggered in the first 4 weeks because neutropenia happens very, very quickly. So that helps us sometimes to remind the patients about when they need to be taking their pills. But it's not an easy regimen to administer to help patients understand those changes with the 5 days on, 2 days off, and when they show back up.
You have very often to do dose reduction or dose delays with TAS 1 and 2?
Only, you know, when there is significant neutropenia. It's in a number of patients. 20-30% of the patients will need some level of dose reduction or dose delay.
And it's most often a dose delay that when they come back at day 28 or after 4 weeks that their white blood cells haven't recovered, so that you have to delay them in some of these patients.
And it's interesting that neutropenia is thought to be a good indicator of who is more likely to respond. Now, it's not a predictive factor because you'll never know that until the patient is on the agent, but it tends to predict almost who's going to be that patient who benefits. Whether that's a pharmacodynamic biomarker or some other form of biomarker is unclear.
Yeah, that's difficult with also other TKIs. With regorafenib, we don't have so many data, but with sorafenib also, for instance, there are data also saying that patients with hand-foot skin reaction, that they do tend to have a better outcome in this situation. With regorafenib, it was not so clearly established, but some of these findings are interesting. But they remain retrospective findings. You can't do a lot with that in clinical practice. Can only help you to endorse psychologically the patient when they have it, that you can tell them, well, there are some data that it may predict a better outcome.
So these drugs are reflected in actual clinical guidelines like the NCCN guidelines or the European ESMO guidelines. Do you think these guidelines help the physician in choosing the right drug in the salvage setting, or do you see any demand in giving a better guideline for the specialists out there?
Well, these guidelines are quite clear. They are evidence-based as well, the ESMO as the NCCN guidelines. And what they state is that in chemorefractory patients as well, regorafenib as trifluridine tipiracil are options. There is no, let's say, no preferred choice, neither in the NCCN, neither in the ESMO guidelines, because the data are not there. There were no head-to-head studies in this situation. So they don't help us to say which one should be given first, because we don't have the data. That's the choice is based on weaker preferences, physician and patient preferences, and maybe a bit more individual, which one first, which sequence first. What they say clearly, the guidelines, however, is that these agents should be given to patients in good condition, good organ function, and that's the reason why often we may propose to give these agents before reintroducing a cytotoxic, again, for instance, a patient who received FOLFOX bevacizumab in the first line, and then after some time his neurotoxicity that he had in the beginning recovered. There's always an option to reintroduce the cytotoxic regimen of the first line. Of course, in the guidelines we don't speak so much about that, but they say clearly that it should be given in good condition, patient in good condition, and that may be an argument to give them before reintroducing the cytotoxic regimen of the first line.
That would be my next question. Although less intensive studied, re-challenge of early line of treatments is used very frequently. Where would you put it into the sequence of treatment for your patients?
Yeah, so most of the data with re-challenge is really retrospective small analyses. So it's not been as well established as, you know, our proof of concept with all the agents we've been discussing through phase 3 studies. So I would leave it as a last line of defense in case you've gone through all the standards, including clinical trials, and then this is really your only potential for the patient. I mean, the patient has to be performant, the patient has to have good organ function, and you know, sometimes, as Dr. Van Cutsem referred to, you have to think about, did I stop, you know, FOLFOX or even FOLFIRI when the patient wasn't really progressing and put them on maintenance, or because of a toxicity I didn't reinitiate that agent? Would we have another opportunity at seeing that happen? But I would really do this after you've exhausted all standard options and, you know, there's no rational clinical trial available for the patient.
And to add on to that, I would only do it in patients who were not progressive while on this regimen, because to my opinion it makes no sense that a patient who was progressive while on treatment with FOLFOX plus a biological or FOLFIRI plus a biological 2 years later to reintroduce that regimen when his tumor was resistant in an early lines. I think this reintroduction topic is only for patients who stopped their initial treatment because of cumulative toxicity or because they were just tired of having the chemotherapy. When there was no clear resistance, no clear progression, then this can be considered in later lines, but not when the patient was really resistant to the regimen.
Exactly. So we have seen recently very interesting data in the salvage setting from early clinical phase trials, like patients with HER2 overexpression, that they might have a benefit of a double blockage of HER2. We have seen the small subset of patients, MSI high, so mismatch repair deficient patient, who might have a benefit out of immune checkpoint inhibitors. Would you like to comment on these trials? Do we see these drugs into the daily clinical routine soon?
So I think these end up being two separate questions. Just with the Heracles study, with the HER2 amplified or HER2 overexpressed, there was clearly a signal. It was a small subgroup of patients, but there's clearly a signal. Also came from, you know, a subset from other studies that HER2 is relevant in colon cancer, and it does seem that a subgroup of patients may benefit. But I think that this is not as much established yet because it's small numbers of patients, and I think it needs to be continuously, and it continues to be addressed in clinical trials. As for the MSI high patients, that again came from small subsets of patients, but the responses were actually pretty dramatic, and there were patients who went into remissions that were long lasting. It's only 4% of all patients, but it seems to have a dramatic effect. In fact, in the NCCN guidelines, it's none. Now, one of the refractory lines includes pembrolizumab or nivolumab in patients with MSI high tumor. The question now, of course, is, and that's being debated and is including clinical trials, is can we move it up the line, or for those patients, can we start them with immune therapy? So I think there's less of a discussion whether patients would benefit in later lines. The discussion now is, should we move them up the line?
Yeah, I think I completely agree. We have to mention also, to add to that, that the number of patients with MSI is only around 5% if you look into the metastatic patients, and the number of patients with an HER2 amplified tumor is even lower. Then we're looking in the patients with a RAS wild type tumor. They're often left-sided tumors, this HER2 amplified, and that's 3 to 5% of the RAS wild type patients. So that's a relatively uncommon group, but for the individual patient, it is important. And if you look at the data of the Heracles study, although it was a small study, 1 out of 3 of the patients had an objective response. So, and again, that has, as was said, that has to be confirmed in larger studies. But the checkpoint inhibitors that's taken, they have activity in patients with an MSI tumor. And indeed, the challenge is, and the question is that really only for the chemorefractory patients, or do we move that up in earlier lines, second line, or even earlier, or in combination with chemotherapy? That all has to be sorted out. But for this 5% of patients with an MSI tumor, it's an important weapon for these patients, and with, as was said, very long-lasting responses sometimes.
So final question from my side, liquid biopsy, so the diagnosis or the detection of circulating cell-free tumor DNA. Do you see in the near future a role of this technique in the salvage setting for choosing an individual treatment for those patients?
I think that the future is really going to move towards more liquid biopsies, and the question that we always have is, is the timing of the biopsy that we've had initially always applies as the tumor evolves through time? And the answer is yes in some instances, but no in most instances. The other one is the heterogeneity of tumors, genetic heterogeneity. You hit one side of the tumor, the other side may look different. You hit one tumor or another, they may look different. They may not apply as much for RAS or BRAF, although there is also the concept of clonal evolution, and some of these RAS tumors may change their clone. And you can only capture that with those liquid biopsies. And I think actually in later lines of therapy it becomes even more applicable, where you expect some of these changes to happen. So I see this as becoming more and more of a standard. However, what I would say is that today we still need to see more data and a little bit more integration into clinical trials to understand really the value, the clinical value of those. But I see the field moving towards liquid biopsies.
Do you also see these still limited to clinical trials, or do we have this in the near future?
I think within a few years we will have that in clinical practice. Of course, the evolution of, let's say, the new drugs has to follow also. Regorafenib and TAS-102, of course, there will be no biomarkers, there are no biomarkers, and there will be no biomarkers for these agents, neither with liquid biopsies. So, but for the other agents, yes, it's coming. We didn't discuss the group of patients with the BRAF mutant tumors, where there are different combinations ongoing that have some activity also in this chemorefractory setting. And in this situation, yes, liquid biopsies will come into clinical practice, in our routine clinical practice, within a couple of years.
I want to thank my experts, Professor Van Cutsem, Professor Saab, for giving this very interesting discussion on the salvage treatment of metastatic colorectal cancer. Thank you very much.